Support for the Living Wisdom podcast is provided by InTouch Pharmaceuticals, a long-term care pharmacy committed to meeting the specialized pharmaceutical needs of their clients. Visit intouchpharma.com. Well, welcome back. We are in the middle of our series where we are exploring the different types of brain diseases that cause dementia. A lot of people obviously think Alzheimer's. It's talked about all the time. But there are far more than that. I'm Christine alongside Deb. So we've already talked Alzheimer's, we've talked vascular, we've talked Lewy body, but there's one more that we need to talk about because you said there are about four prominent ones, right?
Right.
This one is Pick's disease, and like Lewy body, named after a doctor as well, right?
Right. So Pick's disease is a form of dementia. It's a rarer form of dementia. It typically, the onset of it is with a younger age population. And the reason it's called Pick's disease is that Dr. Pick was the individual who identified these two protein deposits. One being tau protein, which is the same protein we talked about when we talked about Alzheimer's disease. And the other one is this protein called TDP43. Not important that people know that, just that it's the second kind of protein where these deposits happen. Yeah. The other thing you're going to hear people refer to in regards to this kind of dementia is what people identify or clinicians sometimes call frontotemporal lobe dementia.
Okay.
Now, the reason it's called that is because that's the areas of the brain that are impacted by these protein deposits. So frontal lobe, this area here behind our forehead, and then temporal lobes, these areas on the sides of our heads, over our ears, behind our ears, these are our temporal lobes. So this type of dementia, this Pick's disease, those are the areas where those protein deposits happen, and that's what in turn determines the very specific kind of symptomology and characteristics that we see with individuals who are diagnosed with this kind of dementia.
Makes sense. And what causes this? I know we talked a little bit about those proteins, but really
So we don't know or understand why that happens. Why do they get those two proteins in these particular areas of the brain? Wow. So this is another one of those forms of dementia that we really don't know a lot about in terms of what is the root cause.
Okay.
We know how it happens, and why we see what we see is because of these abnormal protein deposits in these specific areas. We don't know, and there's a lot of research still being done about why does that happen.
When you say younger, a younger age group, how young are we talking that?
So typically somewhere between the ages of 45 and 64 is where we see, so it's typically midlife, and lots of times people are still working, people are still raising their families. They're still, trying to hold together financial responsibilities and incomes and those kinds of things. So it hits at a really critical time in an individual's life.
And obviously we're going to talk a lot about symptoms and everything like that, but we've kind of given lifespan after diagnosis.
Right.
I'm assuming because of the symptoms we're going to talk about, that probably is all over the charts.
Right. So depending on the age that someone's diagnosed, there's a range of lifespan, somewhere between 3 and 17 years.
Okay.
We know about 60% of all people who are diagnosed with Pick's disease or frontotemporal lobe dementia, about 60% of those individuals are in that age range of 45 to 64. However, we know there have been individuals as young as 21 who have been diagnosed with Pick's disease. So, the range is all over the place, but the majority of people are in that kind of midlife process.
And of course, like all the others, no cure at this time. So let's talk about signs and symptoms, because you said this is very different than what you would think of Alzheimer's for sure.
So one of the things that we talked about when we did our segment on Alzheimer's disease is that one of the very first things that individuals see or experience in someone with Alzheimer's disease is that significant memory loss.
Yeah.
That's typically the first thing that we see because of where in the brain that process starts. In Pick's disease, unlike Alzheimer's disease, memory tends to remain intact for the most part. And the very first significant symptomology that we see in people with Pick's disease is significant behavior and personality changes.
Interesting.
And so it's like, oftentimes families will describe it like someone had a dual personality. And all of a sudden, this person is a completely different person than they've ever been before, by behavior, by language, by actions. And so that is kind of characteristically what we see when people are experiencing or developing this kind of dementia. Now, the reason personality and behavior changes so significantly is because of the specific areas of the brain that are being impacted. I tell people, if you think about, this frontal area of our brain, this temporal areas of our brain, this area of our brain tends to be the same area that gets impacted by alcohol.
Oh, okay.
When people imbibe too much. And so when you think about what does that look like, you start to understand this is the area of our brain that is responsible for impulse control. It's the area of our brain responsible for social graces. It's the area of our brain that gives us the ability to have emotional stability. So when you think about those areas of the brain that are being impacted by Pick's disease, what you see in terms of symptomology and characteristics starts to make a lot more sense because of the way those areas are being destroyed by this disease process. So these people tend to be very impulsive. They will act without thought of consequence. They become very apathetic. They lose all drive and motivation. Don't really care or have no concern about their lack of initiative or motivation. Because that frontal lobe of the brain is being impacted the way it is, they lose the sense of what is socially appropriate or not. So one of the things that's very characteristic of this kind of dementia is that people will say and do whatever comes to their mind.
Wow.
Without any understanding of how it impacts anybody else around them. It's not unusual for these people to say and do things that are completely socially inappropriate. And then when somebody addresses that with them, they just look at you like,
I'm not the problem.
Yeah. What are you talking about?
Oh, wow.
What's the issue? I don't get it. Why are you upset? Okay. And it truly is because they lose that ability to understand those parameters or limits of what's appropriate and what's not.
And you said kind of mood swings along with that.
So again, because that area of our brain that gives us the ability to be emotionally stable starts to get impacted, it's not unusual to see these very severe mood swings from one extreme to the other as people are walking this journey of this kind of dementia. They have very poor decision-making skills. Judgment is very poor, as you can imagine, because they just don't get it.
Right,
They don't know why that would be a wrong thing to do or an unsafe thing to do. The other thing that's interesting is that these individuals with this type of dementia develop what we call hyperorality. And what that means is everything is about what goes in my mouth. So I'm stimulated by this whole oral gratification situation. And so these individuals are very prone to eating things that for the rest of us are considered non-edible. So,
interesting.
So paper, foil, plastic, anything, they will just eat it, like with no awareness that it's not edible. The other thing is that they are compulsive overeaters. So they do not have a shutoff valve. So if you and I eat too much, we start to get uncomfortable. Our brains go, okay, enough, you need to stop.
Right.
These individuals, because of the areas of the brain being impacted, they lose the understanding or that sensation, that trigger that I need to stop, and typically will overeat to the point where they physically will make themselves sick. So weight gain is a very common characteristic. I remember being in the home of an individual where I went to do a dementia assessment, who is diagnosed with this kind of dementia. And in the middle of our conversation, he said to me, hey, I need something to eat. Are you hungry? Would you like something to eat? And I said, no, thank you. I'm good. Well, I need something to eat. I said, that's okay. The man got up, went to his freezer, got a package of raw fish that was frozen, ripped it open, and proceeded during our conversation and interaction to eat raw frozen fish. And I said, well, don't you think you want to warm that up a little bit? Or maybe I can put that in a pan and cook it for you. Oh, no, this is fine. And that's typically what you see, is they have no awareness that they're eating or consuming something in an inappropriate way or something that's inedible. They just don't get it.
So does that lead to them having other complications and issues then?
Could. So, it's not unusual to see these people in emergency rooms because they've consumed something that potentially is going to create a stomach or bowel blockage. It's not unusual to see people in because they've ingested something that's poison or that's undercooked or that's exposed them to some kind of foodborne illness, because they just they totally lose that understanding of what is and isn't appropriate. They have a tendency to develop very compulsive behaviors. They will do the same thing over and over and over again. Wash my hands, 40 times in an hour. Make or remake my bed, 65 times in the course of a morning. So a lot of those kinds of behaviors that you see with people who are diagnosed with an obsessive compulsive disorder, you can see those same kinds of things occur with this kind of dementia. The other thing that happens is there's kind of this progressive loss of language skills where their ability to speak or read or write will change as part of this process. They get to the point with there's such a significant inability to communicate with other people that it starts to interfere with their ongoing daily life and just being able to function independently day to day. It's also not unusual for these people to develop some hand tremors, some balance and walking kinds of changes similar to what we see with Parkinson's. They can have just random muscle weakness that will occur. They can develop that same kind of thing that we talked about when we did our segment with Lewy body dementia, where they just will freeze up. These people will freeze up mid-ambulation, so they'll be walking and all of a sudden not be able to move their legs or their feet. Same way with their speech. They might be in mid-conversation and everything will just stop and they can no longer get words out or be able to communicate. So it's a very challenging kinds of things. Another thing that's significant for them is they lose the awareness of a pain sensation. So these people can cut off the tip of their finger and not know that they've done that. Or they might look and see that they're bleeding and go, hey, I think I need a Band-Aid, without any understanding or realization of pain or how significant their injury is. So paying attention to those kinds of issues is extremely important for caregivers.
And what's interesting is we were saying that there's evidence that this can be shown, 10 years before?
Yeah,
these
so there
symptoms?
have been, right, so there is research that has shown that there are times when, through scans and medical testing, that people can actually identify these PIX bodies, these abnormal proteins in brain tissue, sometimes 10 years
Wow.
before PIX disease ever really develops
Wow.
in terms of symptomology. Yeah.
Well, let's talk about diagnosis and treatment. You were saying so often this is misdiagnosed.
Yes. So one of the things that's very common for individuals who are experiencing this is people don't think about dementia because they're so young.
Yeah.
So people think, well, this can't possibly be dementia. It must be mental health. So these individuals are frequently misdiagnosed with things like bipolar disorder, schizophrenia, obsessive compulsive disorder, a lot of the depression kinds of issues. So people have a tendency to think psychology versus neurology because of the age of the individual.
Wow.
So it's very important that people, as they're seeking out medical assistance and testing, that people are sharing, what was that first symptomology you saw? What is the pattern of changes in that person's personality? They can look very similar to what we see with some of the mental health disorders, but it's very important that you don't just stop with the consideration from a psychology perspective and get a neurologist involved, get somebody involved to look beyond just what appears to be mental health.
We've talked Alzheimer's, Lewy body, and the fact that really 100% diagnosis is if you decide to have an autopsy. Is that the same with this?
Yeah, it is, in that, people are looking for those PIX bodies. However, there is some level of testing with brain imaging, things like PET scans, looking at specifically this frontal and temporal lobe of the brain. If we get a brain scan, and the frontal lobe and these temporal lobes are the only areas we're seeing shrinkage or brain cell death, then it's very possible that what we're dealing with is this specific PIX disease, and because you're not going to necessarily see atrophy or brain shrinkage with mental health disorders.
Yeah. What about medication? They've been instrumental in some, not others. What about this?
Okay. So with this kind of dementia, medication is typically not very helpful. Things that typically people would get treated with, some of the common antidepressants, things like Celexa, Lexapro, Paxil, Prozac, Zoloft, some of those more common medications that you might see used for anxiety or depression, a category specifically that we call serotonin reuptake inhibitors, is a category of antidepressant medication. Those medications do not work for individuals with this kind of dementia. And so typically it can cause symptomology to be exaggerated or accelerated. And so typically if you're thinking or someone's diagnosed with some kind of mental health disorder on these medications, and you see either things not getting better or things getting much worse, that needs to be kind of a red flag and say, okay, maybe we need to revisit. Let's go see a neurologist. Let's find out more about what's going on.
So if medications aren't the answer, there's got to be some non-medical treatment, right?
Right. The other thing that is kind of a red flag for individuals with this kind of dementia from a medication perspective is because we see some of those physical things that look like they could be Parkinsonian kind of things. People tend to want to treat them with the Parkinson's drugs, so levodopa, Simitrel, some of those things that we use to help that involuntary tremor or muscle movement that we see with Parkinson's. For people with Pick's disease, those actually can create death. So it's really important that people, make sure they're dealing with someone who understands the nature of this kind of disease process. And again, that's why we tell people all the time, think about neurology versus psychology. Because if they don't and they treat this person as other kinds of disorders, it could really create a very severe reaction up to possible death.
Wow.
Just because of the nature of how it is.
Kind of seems like this one is a caregiver is so instrumental, like with the example like you said about pulling the like raw fish out of the freezer and eating it, and the different impulses and tendencies, so
yeah,
it kind of feels like that's important.
Yeah, so one of the things that we do to kind of help treat this is really from a non-pharmaceutical kind of approach. It's about environment. It's about, reducing triggers that are going to cause people this obsessive compulsive kind of nature of behavior. It's reducing noise and stimulation. It's simplifying everything in that person's life.
Yeah.
It's removing things that might be triggers. Don't give me free access to food or other things I might put in my mouth that are inappropriate. Limit the places, public places and social gatherings that you take me to lower the opportunity for me to do things that are socially inappropriate. It's important to set limits with these individuals and boundaries about what's okay and what's not okay. These people need a lot of structure, a lot of defined, boundaries. Be very cautious. You have to be very conscious of words that you use and how you talk to these individuals because of the nature of their social filters being gone and their inability to understand appropriate boundaries. Things can be misinterpreted very easily. So as a professional caregiver, even a family member, I wouldn't use words like, "How are you, honey?" Or, "Come on, sweet pea, let's go do," because for somebody with this kind of dementia, they can go, "Oh, she called me honey, she must think I'm hot. She wants a relationship.
Interesting.
She wants some kind of level of intimacy with me." Now, that's not my intent, but that's the way they're going to interpret it. So they're very literal, very concrete in that way. So you have to be very conscious about the fact that these people don't understand what's okay and what's not okay. How I get into your personal space. What's okay for me to have access to. So structure and boundaries and limits are extremely important, whether you're a personal, family member or you're a professional caregiver. All those things, structure is extremely important for these people. They don't function well without routine and structure. They don't deal with change or being kind of left to their own devices. That's when we see a lot of chaos, a lot of disaster happen for these individuals. They get into a lot of altercations. The other thing that's a real challenge in regards to this kind of dementia is that these individuals, for the most part, are in the prime of their life.
Oh, wow.
So oftentimes they're still working full time.
Yeah.
They're in, family situations, marriages, they're raising kids. They're trying to find financial stability and responsibility for their future. So unfortunately, just by the nature of the way this dementia is and how it changes people's personality and behavior, it's not uncommon to see these people getting fired from their jobs because people think what they're seeing in this person is intent. They've just all of a sudden decided not to do their job anymore. They're lazy. They're sexually harassing other people in their work environment. From a law enforcement perspective, it's not unusual to see these people have some kind of legal problem history because they're getting, arrested for public intoxication because of the way they're acting. So people think they must be under the influence of something else. It's not unusual for them to be arrested for public inappropriate indecent exposure because they're in the middle of a park and they have a need to urinate, so they just do it in a public place in front of children or in front of other people. And now the police are involved because obviously there's something that is perverse about this person.
Yes.
That they would do something like this.
Wow.
So again, it's really important that these individuals get really significant, good neurological workups and diagnosis. And again, if our listeners don't leave with any other impression today, it should be about always think neurology before psychology. Because we always need to explore that avenue. If you do that, and from a neurological perspective, everything is normal, then okay,
Perfect.
That's not what you're dealing with, and it could be some other mental health kinds of issue. But I really want to encourage people, if you're seeing these characteristics, if you're experiencing a lot of these same things with a loved one or someone that is connected to that person, let people know, get people connected, and help them understand that this could be something completely different than what people are just automatically assuming it is.
This honestly, all these talking about them just keep reiterating advocacy. You have to advocate for yourself. You have to ask questions. If something seems off or something's not working, you have to go back.
And this is a big challenge for people. Like I said, they're oftentimes losing their primary support financially in their job. Because of their age, frequently they don't qualify for insurance that will give them resources to treatment. Oftentimes relationships are destroyed and marriages are falling apart because people don't understand what this is and feel like so much of this behavior is by choice.
You are not alone. That's why we're here. If you have any questions, please reach out. You can comment below. That's why we're talking about things that do not get talked about enough, because there are people dealing with this, and there's help out there.
Yes, and one of the other things I really want to encourage people to do is to get online and find the organizations and associations that specifically work with individuals of these different kinds of dementia that we've been talking about all along. Help and resources out there, and if you have difficulty finding it, then come find us and we'll help you find who you need.
Support for the Living Wisdom podcast is provided by InTouch Pharmaceuticals, a long-term care pharmacy committed to meeting the specialized pharmaceutical needs of their clients. Visit intouchpharma.com.